Welcome to the deep dive. Have you ever paused to truly appreciate the astonishing precision with which your heart beats and your blood flows, all without, a single conscious thought from you?
Hmm,
It's like an incredibly complex symphony orchestra, perfectly tuned and playing 24/7 deep inside your body.
that's a physiological marvel, isn't it? Today, we're taking a deep dive into the regulation of the heart and vasculature.
Hmm.
Our mission is to really immerse ourselves in this topic, drawing from a comprehensive physiology text and uncover, well, every crucial concept and mechanism. We want you to emerge from this conversation with an elite-level understanding, truly mastering this complex system.
That's right. We're going to peel back the layers, revealing how your nervous system, hormones, and even like the tiny vessels themselves orchestrate this biological ballet to keep your circulation perfectly balanced. We'll explore the intrinsic wisdom of the heart and the external forces that constantly influence it, aiming for those aha moments that illuminate how your body truly works, at a professional level.
We'll begin by defining cardiac output, then delve into the contrasting roles of your sympathetic and parasympathetic nervous systems in heart rate control. We'll explore the crucial reflexes that fine-tune your heartbeat, unpack both the intrinsic and extrinsic mechanisms that govern myocardial performance, and finally, unravel the intricate control of blood flow throughout your peripheral circulation. By the end, you'll see how all these intricate pieces connect to paint, well, a complete and deeply understood picture.
Okay, let's begin with the heart's pumping power. Cardiac output. Fundamentally, cardiac output, or CO, it represents the quantity of blood your heart pumps each minute. It's the ultimate measure of how effectively your heart is performing its vital function, right?
Exactly. And at its core, CO is the product of two vital components, your heart rate, or HR, and your stroke volume, or SV. So CO equals HR times SV. To truly master the control of your cardiac activity, we must deeply understand how both your heart rate and stroke volume are regulated.
Right. And while local factors like temperature can certainly have a minor influence on your heart rate, the real maestro, the primary control system, is your autonomic nervous system, or ANS. It's constantly conducting this symphony behind the scenes without you even realizing it.
That's absolutely right. The typical resting heart rate for an adult is around, say, 70 beats per minute, though it's naturally faster in children and can drop by 10 to 20 beats per minute during deep sleep. For well-trained athletes, it can even hover around 50 beats per minute.
Mm.
Both the sympathetic and parasympathetic divisions of your ANS are always exerting some kind of tonic influence on the heart's natural pacemaker, the sinoatrial, or SA node.
Okay.
The sympathetic system enhances its rhythm, while the parasympathetic system dampens it. Changes in heart rate almost always involve a reciprocal action between these two divisions,
Meaning?
meaning an increase in heart rate means less parasympathetic and more sympathetic activity, and vice versa. They work like a gas pedal and a brake.
And what's truly fascinating is that in a healthy, resting individual, the parasympathetic system tends to be the dominant influence. It's like the brake is slightly on, right?
That's a great analogy.
Right.
We see this vividly if we block these systems pharmacologically. If someone is given atropine, which specifically blocks the parasympathetic effects, takes the foot off the brake, their heart rate substantially increases.
Because that inhibitory brake is removed.
Precisely. But if they're given propranolol, blocking sympathetic effects, easing off the gas, their heart rate only slightly decreases at rest.
Interesting.
And if both systems are completely blocked, the heart rate in young adults averages around 100 beats per minute. That's your heart's intrinsic rhythm, freed from that external ANS control.
Okay, so let's dig into the parasympathetic side first. The vagus nerve, that's the key player here.
Critical player, yes. Its nerve cells are strategically located in fatty tissue near both the SA and AV nodes. The right vagus nerve primarily influences the SA node, effectively slowing or even momentarily stopping its firing. The left vagus nerve, on the other hand, mainly inhibits the AV conduction tissue, potentially causing an AV block. Though it's important to note, there's a significant overlap in their distribution. It's not strictly one or the other.
And the speed. You mentioned speed. The vagus nerve's action is astonishingly fast.
Incredibly fast. Acetylcholine, or ACE, the neurotransmitter it releases, is rapidly broken down by an enzyme called acetylcholinesterase. This means the effects of vagal stimulation decay almost instantly once the signal stops. We're talking rapid decay.
How rapid?
The latency is just 50 to 100 milliseconds. This is because the muscarinic receptors on the heart cells are directly linked to specific potassium channels called KH channels. This direct coupling allows for a remarkably precise, literally beat-by-beat control over both SA and AV nodal function.
Wow, beat by beat.
Yeah, this rapid control gives the parasympathetic system a significant edge at the SA node. Its influence often predominates over the sympathetic effects there. You could observe that even when sympathetic stimulation tries to ramp up the heart rate, if there's simultaneous vagal stimulation, the heart rate response is significantly blunted compared to sympathetic stimulation alone.
So the vagus nerve is like the heart's immediate fine-tuning dial.
Exactly, it's the rapid responder.
Now let's contrast that with the sympathetic pathways. They operate quite differently, you said.
Very differently. Your cardiac sympathetic fibers originate in the upper thoracic and lower cervical segments of your spinal cord. From there, they travel to the paravertebral ganglia, primarily the stellate or middle cervical ganglia. Postganglionic fibers then spread extensively across the heart, forming an epicardial plexus that often follows the coronary vessels deep into the heart muscle.
Okay, so a different route. And the effect is slower.
Much slower, yes. Unlike the instantaneous decay of vagal responses, sympathetic effects fade much more gradually. This is because norepinephrine, or NE, the neurotransmitter released, is removed slowly, either reabsorbed by nerve terminals or slowly cleared by the bloodstream.
Oh, okay.
This slower removal, combined with the fact that NE release itself is a slower process, and its effects are mediated by a slower second messenger system involving cyclic adenosine monophosphate, or CMP.
Well,
It all means sympathetic activity alters heart rate and AV conduction at a much more sluggish pace.
so unlike the lightning-fast vagus nerve, sympathetic activity simply cannot exert that kind of beat-by-beat control over cardiac function.
Absolutely not. It's more of a slower, sustained background influence, like adjusting the orchestra's overall tempo rather than correcting individual notes, to use your earlier analogy.
Got it. So we have these direct nerve inputs. But what about higher up? The brain's role in orchestrating all this.
Oh, it's crucial. What's truly fascinating is how higher brain centers orchestrate this entire cardiac control system. Regions like your frontal lobe, orbital cortex, motor and premotor cortex, anterior temporal lobe, insula, and cingulate gyrus all play a role. Even stimulating specific nuclei in the thalamus, like the midline, ventral, and medial nuclei, can trigger tachycardia, increased heart rate.
And the hypothalamus. I always hear about its role in basic functions.
Incredibly deeply involved. Stimulation of its posterior and posterolateral regions can profoundly change heart rate, mimicking the responses you'd see during intense exercise. These cortical and hypothalamic centers are undoubtedly the origin point for the rapid cardiac reactions you experience during strong emotional states, like excitement or anxiety.
Makes sense.
And they're involved in your body's response to environmental temperature shifts, particularly through the preoptic anterior hypothalamus.
And lower down in the medulla.
Down in the medulla, the parahypoglossal area dynamically balances sympathetic and parasympathetic activity, activating sympathetic pathways while inhibiting parasympathetic ones.
Oh.
It's a reciprocal arrangement. We've even identified distinct cardiac accelerator sites, more numerous on the right side of the medulla, and augmenter sites, which enhance contractility, more prevalent on the left.
Accelerator and augmenter. Interesting distinction.
Yeah, and this anatomical distribution, which is mirrored in the hypothalamus, suggests that sympathetic fibers predominantly descend on the same side of the brainstem.
It makes you wonder how specific these higher-level controls really are. You mentioned the insula.
Ah, yes, the insula. Clinically, we see powerful evidence of this specificity there. It's a deep fold in your brain's cortex, and it exerts distinct regulation over your sympathetic and parasympathetic balance.
How so?
Well, for instance, electrical stimulation of the left insular cortex predominantly elicits parasympathetic responses. Think bradycardia, a slower heart rate, and vasodepression, a drop in blood pressure. Conversely, stimulating the right insular cortex evokes clear sympathetic actions like tachycardia and vasopression, an increase in pressure.
And that has real-world implications.
Profound clinical significance. Patients who suffer acute stroke-induced damage to their left insular cortex often show increased sympathetic tone. This puts them at a significantly higher risk of arrhythmias and, tragically, cardiovascular mortality.
Wow.
Interestingly, damage to the right insular cortex doesn't carry this same elevated risk. It really shows how precisely different brain areas can fine-tune your heart's activity. It's not just a blunt instrument.
Amazing specificity. Okay, let's explore some of the body's incredible auto-adjustments for heart rate. Starting with the baroreceptor reflex, you called it the pressure patrol system.
Ah, yes, pressure patrol. It's a crucial mechanism that initiates an inverse change in heart rate whenever there are sudden shifts in your arterial blood pressure.
Inverse change. So pressure up, heart rate down.
Exactly. When your arterial pressure rises, the activity of these baroreceptors increases, which in turn triggers a decrease in your heart rate. And the reverse happens when pressure drops, pressure down, heart rate up.
And where are these sensors?
These vital baroreceptors are strategically located in your aortic arch and, importantly, in the carotid sinuses, which are small widenings of the internal carotid arteries in your neck. Over an intermediate range of carotid sinus pressures, typically between about 100 and 180 millimeters of mercury, there's a beautiful reciprocal dance between efferent vagal and sympathetic neural activity.
A dance.
Yeah. As pressure increases in that range, vagal activity ramps up and sympathetic activity ramps down. Below that range, sympathetic activity dominates, while above it, vagal activity pretty much takes over completely.
Okay, clear. Next on our list of auto adjustments, the Bainbridge reflex. Volume vigilance.
Volume vigilance, yes. It's named after Francis A. Bainbridge, who way back in 1915 made a remarkable observation. He found that when he infused blood or saline into dogs, their heart rate accelerated. This acceleration happened regardless of arterial pressure, but it was directly tied to central venous pressure and the distension, the stretching of the right side of the heart.
And the vagus nerve was involved.
Critically, he found this response disappeared if the vagus nerves were cut. Bilateral vagotomy abolished it.
So that laid the groundwork.
Foundational knowledge, yes. Many subsequent studies confirmed his findings, adding that the magnitude and even the direction of this response can depend on the prevailing heart rate. For instance, intravenous infusions typically accelerate a slow heart, but might even slow down an already rapid one. It's complex.
And it interacts with the baroreflex.
Absolutely. What's truly fascinating here is its interplay with the baroreceptor reflex. When your blood volume increases, it activates both the Bainbridge reflex, which tends to increase heart rate, and the baroreceptor reflex, which tends to decrease it, because higher volume often means higher pressure initially.
So who wins?
Well, in that delicate balance, the Bainbridge reflex tends to predominate when blood volume is on the rise, while the baroreceptor reflex takes the lead when blood volume diminishes. It's about which signal is stronger in that context.
And the receptors for Bainbridge, they're in the atria.
Primarily located where the great veins join the atria, these atrial receptors sense the stretch from increased volume. They send their signals via the vagus nerves directly to the brainstem. From there, efferent impulses travel back to the SA node, influencing it through both the sympathetic and parasympathetic divisions of the ANS.
Is it just heart rate?
The response is remarkably selective for heart rate. Even with a significant reflex increase in heart rate, changes in ventricular contractility are generally minimal, and it's not typically accompanied by a widespread increase in sympathetic activity in peripheral arterioles. It's quite focused.
Anything else triggered by atrial stretch?
Yes, beyond heart rate, atrial receptor stimulation also enhances urine volume. This is mainly due to a neurally mediated reduction in vasopressin secretion, though reduced renal sympathetic activity also plays a part. And here's another key piece. Stretched atria also release atrial natriuretic peptide, or ANP.
ANP, that rings a bell clinically.
It should. In patients suffering from congestive heart failure, the increased ANP released actually helps reduce fluid retention. It lowers central venous pressure and cardiac preload, all by enhancing the kidney's excretion of sodium chloride and water. It's a vital intrinsic compensatory mechanism when the heart is struggling.
Very important connection there. Okay, shifting to another, maybe more commonly noticed auto adjustment, respiratory sinus arrhythmia.
Ah, yes, that natural rhythmic variation in your heart rate linked to breathing.
You can definitely feel it sometimes. Your heart rate speeds up when you inhale and slows down when you exhale. It's often much more noticeable in children, right? Almost like their heart is dancing to their breath.
It really is. The neural basis for this is quite precise. Sympathetic activity tends to rise during inspiration, and vagal activity increases during expiration.
And it's mostly the vagus.
Almost entirely due to the vagus. Because acetylcholine, the vagal neurotransmitter, is so rapidly broken down, your heart rate can rhythmically vary with respiration thanks to these swift changes in vagal activity. The slower removal of norepinephrine means sympathetic rhythmic changes simply aren't fast enough to cause these rapid oscillations in heart rate.
So what causes this link between breathing and heart rate? Reflexes, the brain.
It's actually a combination of both reflex and central factors. On the reflex side, lung stretch receptors get activated during inspiration. They send impulses through the vagus nerve, triggering a reflex increase in heart rate.
Okay.
Additionally, the decreased pressure inside your chest during inspiration boosts venous return, which leads to right atrial stretch and, in turn, elicits the Bainbridge reflex we just talked about.
So multiple reflexes contributing. And central factors.
Yes. The respiratory center in the medulla directly influences the cardiac autonomic centers. There's crosstalk. This is supported by studies using heart-lung bypass. Even with collapsed lungs and constant blood pressure, rhythmic heart rate changes still occur with just the movement of the ribcage, strongly suggesting a direct interaction between the medullary, respiratory, and cardiac control centers.
Fascinating interplay. Now let's consider the chemoreceptor reflex. This is about blood chemistry, right? Subtle shifts sending signals.
Exactly. When peripheral chemoreceptors, like those in your carotid arteries, are stimulated, say, by low oxygen, they consistently increase your breathing rate and depth. That's their main job. Yet surprisingly, their direct effect on your heart rate in a normally breathing person is often only slight.
Why only slight? If low oxygen is detected, wouldn't the heart need to react strongly?
It's because the heart's response is a result of a complex interplay between primary and secondary reflex mechanisms. The primary effect, if you isolate it, directly excites the medullary vagal center. This would dramatically decrease your heart rate. But there are secondary effects, mediated by the increased breathing itself, that tend to inhibit this vagal center, thereby accelerating heart rate.
So they cancel each other out?
Often, yes. Because these opposing effects often neutralize each other, the net change in heart rate is usually only moderate under normal circumstances.
Can we see that primary inhibitory effect more clearly sometimes?
Absolutely. We get a compelling example when the lungs are completely collapsed, perhaps during surgery, and blood oxygenation is handled artificially. Under these precise conditions, if the carotid chemoreceptors are stimulated, it causes intense bradycardia and even some AV block.
Wow.
This profound slowing is mediated primarily by vagal fibers, clearly illustrating just how significant that primary heart slowing effect can be when the secondary respiratory counter effects are removed. It's like pulling back the curtain on one specific part of the system.
So the key point for a deeper understanding is that the hyperventilation normally triggered counteracts the direct slowing effect.
Exactly. The pulmonary hyperventilation, normally triggered by chemoreceptor stimulation, influences heart rate in two secondary ways. It initiates more pronounced pulmonary inflation reflexes, and it produces hypocapnia, or reduced CO2 in the blood. Both of these influences tend to counteract the primary cardiac slowing response, effectively accelerating heart rate relative to what it would be. So when hyperventilation isn't prevented, the primary and secondary effects create that careful balance, leading to only moderate heart rate changes.
Is there a clinical situation where this really stands out?
There is. Consider the case described in the literature of a quadriplegic patient dependent on artificial respiration. When their tracheal catheter was briefly disconnected, inducing hypoxia and hypercapnia,
What happened?
profound bradycardia developed within seconds. Their heart rate plummeted from around 65 to approximately 20 beats per minute, just catastrophic slowing.
Goodness.
But this dramatic slowing was entirely preventable by blocking efferent vagal activity with atropine beforehand, and it could be delayed by hyperventilating the patient just before disconnection.
So that really isolates the vagal chemoreceptor-driven slowing.
Very clearly shows the direct vagal mediation and chemoreceptor involvement in this profound response when breathing compensation is absent.
Okay, one more reflex set. Ventricular receptor reflexes, sensors in the ventricles themselves.
That's right. Sensory receptors located near the endocardial, the inner surface, and epicardial, the outer surface, of your ventricles. When these are excited, they cause both your heart rate and peripheral resistance to diminish. However, their exact physiological functions day-to-day are still, well, an area of active research, not fully pinned down.
But they are linked to fainting, right? Vasovagal syncope.
Yes, clinically, this is thought to be the mechanism behind vasovagal syncope. Vigorous ventricular contraction combined with diminished filling, maybe from dehydration or just standing quietly for too long, can stimulate these ventricular receptors. This triggers a cascade of autonomic neural changes, resulting in that profound, vagally mediated bradycardia and a generalized arteriolar vasodilation. Blood pressure plummets.
And down you go.
Exactly. It's a sudden, temporary drop in blood flow to the brain that can cause a person to lose consciousness.
All right, let's shift our focus now to myocardial performance, how the heart muscle itself works and is regulated both internally and by these external forces we've been discussing. It's quite remarkable to consider that the heart can initiate its own beat and adapt to changing conditions, even without any direct nervous or hormonal control, isn't it?
Indeed. The myocardium possesses an inherent ability to adapt to changing hemodynamic conditions. It has intrinsic regulation. For example, racing greyhounds whose hearts have been surgically denervated and completely cut off from the ANS can still achieve substantial increases in cardiac output during a race.
How?
Primarily through an increase in stroke volume. While circulating catecholamines, adrenaline and noradrenaline, do contribute somewhat, This powerfully illustrates the heart's impressive intrinsic capabilities, its own built-in wisdom, if you like.
So at the core, we have two principal intrinsic mechanisms driving this self-sufficiency for that deep understanding.
That's right. The Frank-Starling mechanism and rate-induced regulation. These are the heart's fundamental ways of adapting its performance on its own.
Before we dive into those, are there clinical situations where this intrinsic regulation becomes even more important because the external controls are compromised?
Absolutely. From a clinical vantage point, it's important to recognize situations where the heart is partially or completely denervated. A surgically transplanted heart is totally denervated, at least initially, although some intrinsic parasympathetic fibers might eventually persist or regrow.
Okay.
Drugs like atropine or propranolol can acutely block vagal or sympathetic influences, respectively, forcing reliance on intrinsic mechanisms. Certain older medications, like reserpine, used to deplete norepinephrine stores, severely restricting sympathetic control. And crucially, in chronic congestive heart failure, the heart's own norepinephrine stores are often significantly diminished, profoundly weakening sympathetic influences over time. So the intrinsic properties become paramount.
Got it. Okay, let's unpack the Frank-Starling mechanism first. This is foundational law, right? Relating to the stretch of the heart muscle fibers.
Foundational is the right word. It relates to changes in the resting length of myocardial fibers, influenced by both preload the stretch before contraction and afterload the resistance the heart pushes against.
Let's start with preload. More filling means more stretch.
Exactly. For preload, when ventricular filling pressure increases, the ventricular volume and thus the myocardial fiber length increase. This leads to an increased stroke volume that precisely matches the venous return, more in, more out.
And how does stretch lead to a stronger contraction?
The primary cellular mechanism involves a stretch-induced change in the sensitivity of the cardiac myofilaments, the contractile proteins to calcium ions. Stretch makes them more responsive to the available calcium, allowing for stronger contractions.
Is there a limit?
Yes. This holds true up to an optimal fiber length. Beyond that, overstretching can actually depress performance. There's a sweet spot.
Okay, and the afterload effect,
Yep.
coping with resistance.
Right. The heart powerfully adapts to the counterforce it encounters during ejection. An increased afterload, like high blood pressure, initially reduces stroke volume because it's harder to push blood out.
Yeah.
But the ventricle doesn't eject as much, so more blood is left behind. This increases the end diastolic volume and fiber length for the next beat. This increased stretch eventually enables a normal stroke volume to be pumped against that greater resistance.
And again, calcium sensitivity is key.
It appears to be the major underlying factor here too, yes. The stretched muscle just works better with the calcium it has.
How does heart rate fit in with this intrinsic regulation?
Well, the heart's adaptation to altered heart rate also involves changes in ventricular volume, linking back to Starling. For instance, during bradycardia, a slow heart rate, the extended duration of diastole allows for significantly greater ventricular filling time.
More filling, more stretch.
Exactly. The resulting increase in myocardial fiber length then increases stroke volume via the Starling mechanism. This increased stroke volume can effectively compensate for the reduced heart rate to maintain a consistent cardiac output, at least up to a point.
Here's something maybe deeper. You mentioned Laplace's relationship. Dilated hearts needing more force?
Ah, yes, Laplace. This is critical. According to Laplace's relationship, a dilated larger ventricle needs appreciably greater fiber force, more tension development in its walls to generate the same intraventricular systolic pressure compared to a normal-sized ventricle.
So it's less efficient.
Much less efficient. It means a larger dilated heart has to expend significantly more energy, burn more oxygen, to do the same amount of pumping work. This contributes to the progression of heart failure.
And ventricular function curves. They show this visually.
They're a powerful tool to represent this mechanism, yes. An upward and leftward shift in these curves may be seen with a norepinephrine infusion vividly signifies improved contractility, better pumping efficiency. The heart pumps more volume at any given filling pressure.
And the opposite.
Conversely, a downward and rightward shift indicates impaired contractility. The heart pumps less volume for the same filling pressure, often seen in heart failure. Understanding these shifts is absolutely key to truly grasping myocardial performance assessment.
And this whole Frank-Starling thing, it's vital for balancing the two sides of the heart, right and left ventricles?
Absolutely vital, because the ventricles are arranged in series blood flows from right to left through the lungs. Their outputs must be precisely matched over time. The Frank-Starling mechanism ensures this. If the right ventricle temporarily pumps slightly more blood than the left, the increased return to the left atrium raises left ventricular filling pressure and stretch, boosting its output to match the right. It prevents catastrophic imbalances.
Makes sense. If they got out of sync, you'd quickly have fluid backing up in the lungs or the body.
Disaster. Under normal physiological conditions, your left atrial pressure consistently exceeds your right atrial pressure by a few millimeters of mercury to maintain this equilibrium. It reflects the slightly higher workload of the left ventricle pumping against systemic pressure.
And clinically, this pressure difference explains things like atrial septal defects.
Exactly. In individuals with congenital atrial septal defects, where there's an abnormal opening between the atria, the normally higher left atrial pressure causes blood to shunt from the left side to the lower pressure right side. It flows down the pressure gradient.
Okay, crystal clear. Moving on to the second intrinsic mechanism, rate-induced regulation, frequency affecting force.
Precisely. Myocardial performance is also profoundly regulated by the frequency of contraction. It's sometimes called the TREP effect or staircase phenomenon. For example, if you take an isolated strip of heart muscle, like a papillary muscle, and stimulate it at a higher frequency, say, moving from one beat every few seconds to a beat every 0.63 seconds, its force of contraction can progressively increase, sometimes by over 5 times its initial strength.
5 times? How does that happen? What's the mechanism?
It occurs through 2 primary mechanisms, both related to calcium handling. First, a higher frequency of stimulation means more action potential plateaus occur per minute. Even if the duration of each individual plateau is slightly shorter at faster rates, the total time spent with calcium channels open per minute increases. This leads to a gradual accumulation of intracellular calcium.
More calcium, stronger contraction.
Right. Second, there's evidence that with successive depolarizations at higher frequencies, the inward calcium current itself progressively increases in magnitude, and its inactivation slows down. This enhances the effect, leading to even greater calcium influx and consequently stronger contractions.
What about irregular beats, like extrasystoles?
Good question. Transient changes in the intervals between heartbeats also profoundly affect contraction strength, illustrating these principles. Premature contractions, often called extrasystoles or PVCs, are typically weak. Why? Because the heart simply doesn't have enough time to fill properly before that early beat. Less filling, less stretch, weaker beat via Starling.
Okay, that makes sense. But what about the beat after the premature one?
That's where it gets interesting. The subsequent post-extrasystolic contraction, which occurs after a longer than usual pause, the compensatory pause, is often remarkably strong.
Why stronger?
Because of the exaggerated filling during that longer diastolic interval. More filling time means more stretch, plus there's potentially more calcium available that had accumulated due to the previous beats.
There's a name for this relationship.
Yes, this intricate relationship between the timing of a beat and its strength is precisely described by the mechanical restitution curve. It illustrates how the strength of a premature beat directly relates to how early or premature it is, and also predicts the strength of the following beat.
And the cellular basis for the weak premature beat. Something about calcium reloading.
Exactly. At the cellular level, the underlying reason for the weakness of very premature beats relates to a significant lag, about 500 to 800 milliseconds, for the calcium stored within the sarcoplasmic reticulum to become fully reloaded and available for release in response to the very next depolarization signal.
So it needs time to recycle the calcium effectively.
Precisely. The heart muscle needs that crucial time to sequester calcium back into the SR and get it ready for the next optimal contraction. Too soon, and the trigger releases less calcium.
Okay, so the heart has these amazing intrinsic ways to adapt, but you said extrinsic factors can often overwhelm them.
Yes, that's crucial for a complete understanding. While the heart possesses truly impressive intrinsic adaptive capabilities, extrinsic factors originating outside the heart itself can often exert a more powerful influence, especially under stress or changing physiological demands. These external regulatory factors can be broadly categorized into nervous control, which we've touched on regarding heart rate, and chemical or hormonal control.
Let's revisit nervous control, but focus on contractility this time. Sympathetic activity.
It boosts pumping strength, right?
Powerfully enhances both atrial and ventricular contractility. For example, stimulating the sympathetic nerves to the heart, like the left stellate ganglion, can cause a substantial and rapid rise in peak left ventricular pressure and the maximal rates of pressure change, DPDT. It makes the heart pump harder and faster.
And it affects relaxation, too.
Yes, critically. This increased sympathetic drive also shortens the duration of systolic contraction and increases the rate of ventricular relaxation. This might seem counterintuitive, but faster relaxation actually aids ventricular filling for the next beat, especially at high heart rates.
What's happening at the cellular level to cause all this?
Okay, getting into the weeds here. At the cellular level, this remarkable effect occurs when neurally released norepinephrine or circulating catecholamines activate beta-1 adrenergic receptors on the cardiac cell membrane.
Baroreceptor. All right. This activation then triggers an enzyme called adenylate cyclase, leading to an increase in the intracellular messenger, cyclic AMP, or CAMP. This CMP then activates another enzyme, protein kinase A, which phosphorylates specific proteins involved in calcium handling.
Which proteins?
Key targets include phospholamban on the sarcoplasmic reticulum. Phosphorylating it removes its inhibitory effect on the calcium pump, circa, facilitating faster calcium uptake into the SR and promoting quicker relaxation. Another target is troponin I, part of the contractile machinery, whose phosphorylation also contributes to faster relaxation by decreasing calcium sensitivity.
And for contraction strength.
CAM-PPKA also phosphorylates L-tight calcium channels in the cell membrane, increasing calcium influx during the action potential plateau. This triggers greater calcium release from the sarcoplasmic reticulum, leading to significantly increased contractile strength.
So basically, sympathetic stimulation tells your heart cells to become much better and faster at handling calcium more and stronger squeeze, faster removal, quicker relaxation.
That's an excellent summary. It's like giving the cells calcium pumps and release mechanisms, a turbo boost.
And visually on those function curves.
Increased sympathetic activity effectively shifts the ventricular function curves upward and to the left. This visually represents improved ventricular performance and pumping efficiency, more bang for your buck at any given filling pressure.
Okay. Now the flip side. Parasympathetic influences on contractility. Less pronounced, you said earlier.
Generally less pronounced, especially in the ventricles compared to the atria, but still significant. Parasympathetic influences, primarily from the vagus nerves, act as a counterbalance. We know they inhibit the pacemaker, atrial myocardium, and AV conduction tissue. While their direct negative effect on ventricular contractility is weaker than the sympathetic positive effect, vagal stimulation still demonstrably shifts the ventricular function curve downward and to the right, signifying a reduction in myocardial contractility.
So it does weaken the pumps somewhat.
Yes, it exerts a negative inotropic effect. This effect is directly opposed by drugs that block muscarinic receptors, like atropine.
And the mechanisms. How does A-suite weaken contraction?
The mechanisms involve acetylcholine, AEA, released by the vagal nerves, interacting with muscarinic M2 receptors on the cardiac ventricular cell membrane. This activation has a couple of key effects. First, it directly inhibits adenylate cyclase via an inhibitory G protein, GC. This lowers CMP levels, counteracting the sympathetic effect.
So it directly opposes the sympathetic pathway.
Yes, reducing CMP diminishes calcium channel phosphorylation and activity, leading to less calcium influx and thus weaker contractions.
Is there an indirect effect, too?
There is. AC can also indirectly inhibit the release of norepinephrine from neighboring sympathetic nerve terminals. This is called presynaptic inhibition, so it actively antagonizes the sympathetic stimulatory effects right at the source.
And can sympathetic nerves inhibit vagal nerves?
Interestingly, yes. Sympathetic norepinephrine and a co-transmitter called neuropeptide Y, or NPY, can inhibit ACE release from vagal fibers. It showcases a fascinating, intricate two-way inhibitory interaction, a crosstalk, between these two crucial autonomic systems right within the heart tissue.
A real tug-of-war at the nerve endings. Okay, beyond direct nervous control, chemical factors hormones also orchestrate myocardial performance. Adrenaline and noradrenaline from the adrenal glands.
Right, the adrenomedullary hormones, epinephrine, adrenaline, and norepinephrine, noradrenaline. They're released under the same conditions that activate your sympathetic nervous system, like stress or exercise. However, under most normal physiological conditions, their direct cardiovascular effects are usually quite minimal when compared to the impact of the norepinephrine released directly from cardiac sympathetic nerve fibers onto the heart cells. The local nerve release is generally more important for moment-to-moment control.
What about steroids? Adrenocortical hormones.
The influence of adrenocortical steroids on myocardial contractility is a topic that has generated some debate over the years. There's evidence that cardiac muscle from animals whose adrenal glands have been removed tends to fatigue more easily. We also know that glucocorticoids, like hydrocortisone, can potentiate the effects of catecholamines, possibly by inhibiting their uptake by non-neuronal cells, leaving more available to act on receptors.
And clinically, this is important in Addison's disease.
Acutely evident, yes.
Yep.
In patients with adrenocortical insufficiency, Addison's disease. They often experience significant cardiovascular problems. These can include a dangerous fall in blood volume, severe hypotension, and in critical cases, full-blown cardiovascular collapse, known as an Addisonian crisis. Lack of cortisol has serious cardiovascular consequences.
Okay. Thyroid hormones. You mentioned they boost contractility.
Powerful enhancers, yes. In hyperthyroidism, in overactive thyroid, the rates of ATP hydrolysis by the myosin contractile proteins and the rate of calcium uptake by the sarcoplasmic reticulum are significantly increased. The heart works faster and harder. The opposite effect, a depression of these processes, occurs in hypothyroidism, an underactive thyroid.
Does it change the heart muscle itself?
Yes. Thyroid hormones also boost cardiac protein synthesis. Chronically high levels can lead to cardiac hypertrophy, an enlargement of the heart muscle. They also affect the type of myosin isoenzymes expressed, shifting toward forms with higher ATPase activity, making contraction faster.
How does thyroid hormone actually do this at the cellular level? Is it changing genes?
Both genomic and non-genomic pathways are involved. The main genomic route involves thyroid hormone, specifically T3, entering the nucleus and regulating the expression of T3 responsive genes. These genes code for proteins involved in calcium handling, like the SR calcium pump circa, and the contractile proteins themselves, like myosin heavy chains.
So it reprograms the cell over time.
Exactly. In hyperthyroidism, this leads to increased messenger RNA for these key myocyte proteins, resulting in those increased rates of contraction and relaxation. But there's a catch.
What's the catch?
Paradoxically, this increased activity comes at a cost. ATP use is less efficient and there's greater heat loss. If left untreated, severe hyperthyroidism can actually lead to high-output heart failure due to this chronic metabolic overactivity and inefficiency.
So clinically, thyroid levels are critical for heart function.
Absolutely. Depressed cardiac activity is a hallmark of hypothyroidism, while hyperthyroidism presents with significantly increased activity, tachycardia, palpitations, forceful heartbeat. And interestingly, some cardiovascular manifestations of hyperthyroidism can also be indirectly linked to the body's overall increased metabolic rate. This causes widespread arterial vasodilation, which reduces peripheral resistance and, consequently, forces an increase in cardiac output to maintain blood pressure.
Wow, complex interactions. What about insulin? Usually think metabolism, not heart muscle strength.
True, but insulin also has a positive inotropic effect on the heart. It directly increases the force of muscle contraction. What's particularly noteworthy about this effect is that it's evident even when hypoglycemia, low blood sugar, is prevented, and even when adrenergic receptors are blocked.
So it's not just a side effect of blood sugar changes or adrenaline.
Correct. In fact, its positive inotropic effect is even potentiated, made stronger, by adrenergic receptor antagonists, highlighting an independent mechanism of action, although the exact pathway is still debated.
And glucagon, another hormone usually linked to blood sugar.
Glucagon, while likely not a primary regulator of normal cardiovascular function day to day, has potent positive inotropic and chronotropic heart rate increasing effects. It's actually used clinically sometimes to enhance cardiac performance in specific situations, like beta blocker overdose.
How does it work? Same as adrenaline.
It activates adenylate cyclase to increase myocardial KMP, much like catecholamines do, but it binds to a distinctly different receptor mechanism on the heart cell. So it bypasses the beta receptors, but achieves a similar downstream effect. Increased CAM-AMP, leading to increased calcium influx and facilitating calcium release and reuptake by the SR, boosting the heart's pumping power.
Useful backup system, maybe. What about hormones from the pituitary gland?
As for anterior pituitary hormones, the cardiovascular problems seen in hypopituitarism are largely related to the associated adrenal and thyroid deficiencies that often accompany it. However, growth hormone, especially when combined with thyroxine, thyroid hormone, has been shown to restore cardiac performance in animals whose pituitary has been removed. Furthermore, in some experimental models of heart failure, growth hormone alone has shown some promise in increasing cardiac output and myocardial contractility, suggesting a potential direct role, though its clinical use for this is complex.
Okay, last one in this section, blood gases. Oxygen, CO2, pH affecting the heart muscle directly.
Yes, they do have direct effects on the myocardium itself, although, as we keep emphasizing, in most physiological situations, the powerful chemoreceptor reflexes we discussed earlier typically dominate the overall cardiovascular response.
But what is the direct effect of low oxygen, for example?
A low partial pressure of oxygen, hypoxia, has a direct depressant effect on the heart muscle. This seems to be primarily mediated by changes in intracellular pH that occur during hypoxia. A reduction in intracellular pH diminishes the release of calcium from the sarcoplasmic reticulum and also decreases the myofilament sensitivity to calcium, leading to weaker contractions. The muscle just doesn't respond as well.
And high pH, or higher oxygen.
Conversely, an increase in intracellular pH actually enhances calcium sensitivity, thereby strengthening contractions. High oxygen levels, hyperoxia, don't typically have a major direct positive effect and can even cause vasoconstriction elsewhere. So it's mostly about avoiding the negative effects of low oxygen and low pH on the heart muscle itself.
Okay, that wraps up myocardial performance. Let's now shift our focus outwards to the regulation of the peripheral circulation, how blood flow is precisely controlled throughout your entire body. You said it's a dual control system?
Exactly. This system operates under a sophisticated dual control, centrally, orchestrated by your nervous system, and locally, governed by the specific conditions and needs within the tissues themselves.
And the key players here are the arterioles.
The arterioles are truly pivotal. They are the primary resistance vessels in your circulatory system. Think of them as the main taps controlling flow to different regions. They play a crucial role in maintaining overall arterial blood pressure. The smooth muscle lining their walls meticulously controls their lumen diameter, adjusting resistance.
And they're usually somewhat constricted.
Yes, these vessels maintain a state of partial contraction known as vascular tone. This is essential because if all resistance vessels dilated simultaneously, total peripheral resistance would plummet and arterial blood pressure would fall catastrophically. So the vascular smooth muscle of arterioles controls total peripheral resistance, arterial and venous tone, and the precise distribution of blood flow.
All right, let's dive into the intrinsic or local control first. Autoregulation. Tissues controlling their own flow.
Autoregulation is a remarkable ability of many tissues, particularly vital ones like the brain, heart, and kidneys, to adjust their own blood flow to precisely match their metabolic activity. This means they can maintain a remarkably constant flow despite significant changes in the pressure driving that flow, the arterial blood pressure, within a certain range.
How do they do that? One mechanism is myogenic, muscle-based.
Yes, the myogenic mechanism is a key component. The vascular smooth muscle itself directly senses changes in pressure. It contracts in response to an increase in transmural pressure. That's the pressure difference, stretching the vessel wall, and relaxes when that pressure decreases.
What triggers the contraction when stretched?
It's thought to involve the activation of stretch-sensitive ion channels in the smooth muscle membrane, leading to depolarization and subsequent opening of voltage-gated calcium channels, causing calcium influx and contraction.
Does this play a big role normally?
Under normal resting conditions, the myogenic mechanism's contribution to overall resistance might be smaller compared to neural control or local metabolites, especially because the baroreceptor reflex works hard to keep arterial pressure constant. But it becomes critically important in situations where local transmural pressure changes significantly, like when you stand up and gravity increases pressure in the leg vessels. It helps prevent excessive blood flow pooling.
And you mentioned TRP channels at the cellular level, getting really specific here.
Yes, for a really deep dive, fascinating research implicates transient receptor potential, or TRP, channels in this myogenic response. The proposed pathway suggests that increased pressure activates an enzyme called phospholipase C. This generates a molecule called diacylglycerol, DAG. DAG, perhaps along with mechanical stretch itself, activates specific TRP channels in the smooth muscle membrane. Their activation causes depolarization, which then opens L-pipe voltage-gated calcium channels. This leads to an increase in intracellular calcium and ultimately increased muscle tone and vasoconstriction.
An incredibly precise molecular cascade just from pressure changes. Amazing. What's the other main local control? Metabolic.
Metabolic regulation is arguably even more important for matching flow to tissue needs. This is a profound mechanism where the metabolic activity of a tissue directly governs its own blood flow. If there's an inadequate oxygen supply relative to demand, or if metabolic byproducts accumulate, the tissue prompts the local formation and release of specific vasodilator metabolites.
And these chemicals relax the arterioles.
Exactly. These substances act locally to dilate the resistance vessels, the arterioles, thereby increasing blood flow to deliver more oxygen and wash out waste products, precisely meeting the tissue's heightened demands.
What kind of substances are we talking about?
Well, the list of candidate vasodilator substances is long and varies somewhat by tissue. Common factors include increased potassium ions released from active muscle, inorganic phosphate from ATP breakdown, increased osmolarity, and crucially decreased oxygen levels. Hypoxia itself can directly relax smooth muscle. Adenosine is a very important vasodilator, especially in the coronary circulation and likely skeletal muscle. Lactic acid leading to lower pH, also contributes. And various prostaglandins can play a role too. It's likely a combination of factors working together.
You mentioned basal vessel tone earlier. What maintains that baseline constriction?
Right, for this metabolic control to function effectively by causing dilation, there must be a starting point, a basal vessel tone, a foundational tonic activity or partial constriction in the vascular smooth muscle that exists independently of the nervous system. This baseline tone is maintained by several factors, partly by the inherent myogenic response to the normal stretch of blood pressure, partly perhaps by the relatively high partial pressure of oxygen in arterial blood, which can be mildly constricting, and fundamentally by the presence of intracellular calcium required for any muscle contraction.
And reactive hyperemia. That demonstrates this metabolic control.
A powerful demonstration, yes. Reactive hyperemia. If arterial inflow to a vascular bed is temporarily stopped, say by inflating a blood pressure cuff on your arm for a few minutes, upon release of the cuff, the blood flow to that limb immediately overshoots the pre-occlusion level. It becomes much higher for a short period. Both the peak flow achieved and the duration of this hyperemia are proportional to how long the occlusion lasted. This strongly supports the metabolic mechanism. The longer the occlusion, the more vasodilator metabolites accumulate, leading to a stronger dilation response when flow is restored.
Makes sense. Now, how do the small arterioles coordinate with the larger arteries feeding them?
That's a remarkably clever aspect. Coordination of arterial and arteriolar dilation. When arterioles relax in response to vasodilator metabolites from active tissue, the resistance drop isn't just localized. It can lead to diminished resistance in the small upstream arteries that feed those arterioles as well.
So the dilation spreads backwards.
It seems to, yes. This further increases blood flow to the active area, beyond what simple arteriolar dilation alone could achieve. There are two primary mechanisms proposed for this coordinated dilation. First, the vasodilation signal might propagate electrically or chemically, like a wave, from the arterioles back along the vessel wall to the small arteries.
And the second?
Second, the metabolite-mediated dilation of arterioles accelerates the speed of blood flow in the feeder arteries. This increased flow velocity generates higher shear stress on the arterial endothelium, the inner lining. This shear stress then induces the endothelium to release powerful vasodilators like nitric oxide, NO, prostacyclin, perhaps hydrogen peroxide, or epoxyeicosatrienoic acids, EETs. This is called flow-mediated vasodilation.
So the faster flow itself causes the upstream vessel to relax more. Clever feedback loop.
Very clever. It ensures the entire supply line opens up appropriately to meet downstream demand.
And clinically, understanding this is vital for things like claudication, pain on walking.
Absolutely vital. In patients with peripheral artery disease causing intermittent claudication, the arteries supplying the leg muscles might be severely narrowed. Even at rest, local metabolites might cause maximal dilation of the downstream arterioles just to get enough blood through. So when the patient starts walking and oxygen demand dramatically increases, the vessels simply cannot dilate any further. Blood flow cannot increase enough to meet the muscle's needs, leading to ischemia and intense cramping pain. It's a clear example of local metabolic control hitting its absolute limit due to upstream disease. Okay, that covers local control.
Yeah.
Now for the extrinsic control of peripheral blood flow. Sympathetic nerves again, but this time controlling vessel diameter. Sympathetic neural vasoconstriction plays a dominant and profound role in regulating overall peripheral resistance and blood pressure. Several regions within your cerebral medulla significantly influence cardiovascular activity. As we touched on earlier, the dorsolateral medulla, often called the rostral ventrolateral medulla or RVLM, the depressor region, strongly evokes widespread vasoconstriction alongside cardiac acceleration and enhanced myocardial contractility.
And the depressor region.
Yes, areas caudal and ventromedial to this, sometimes called the caudal ventrolateral medulla or CVLM, the depressor area, decrease arterial blood pressure primarily by inhibiting the tonic activity of the depressor region. RVLM.
So the default is some level of constriction.
Exactly. These cerebrospinal vasoconstrictor regions, particularly the RVLM, are tonically active, constantly sending out baseline signals down the spinal cord to sympathetic preganglionic neurons. When their activity increases, it raises the frequency of impulses traveling out via sympathetic nerves to the blood vessels. This leads to more release of norepinephrine onto the smooth muscle,
which causes constriction via alpha receptors.
Precisely, a constrictive alpha-1 adrenergic effect on most resistance vessels. Conversely, inhibiting these medullary centers diminishes that impulse frequency, leading to less norepinephrine release, relaxation of the smooth muscle, and vasodilation. So neural regulation of vessel tone is primarily about finely tuning the frequency of these sympathetic nerve impulses.
What happens if you cut the sympathetic nerves to a limb?
If you surgically cut or pharmacologically block the sympathetic nerves to a limb, blood flow immediately increases dramatically, maybe several-fold, because that tonic vasoconstrictor drive is removed. Though, interestingly, over time, intrinsic myogenic and metabolic mechanisms work to restore some degree of vascular tone even without the nerves.
And those pressure waves, Traub-Herring and Mayer waves, they reflect changes in this sympathetic tone.
Yes, these medullary vasomotor regions also undergo fascinating rhythmic changes in their tonic activity, which can manifest as oscillations in arterial pressure and sympathetic nerve firing. We observe Traub-Herring waves occurring at the frequency of respiration, possibly due to interaction with the respiratory centers, and slower Mayer waves, maybe around 0.1 Hz, whose origin is more complex, but also reflects cyclic fluctuations in sympathetic drive to the vessels.
Does this sympathetic constriction affect veins as well as arteries?
Oh yes, the sympathetic constrictor influence extends to both resistance vessels, arteries and arterioles, and capacitance vessels, primarily veins and venules. Sympathetic fibers supply arteries, arterioles, and veins, although their influence might be slightly less dense on the largest arteries.
And veins respond strongly.
Your capacitance vessels, your veins, respond even more strongly, or at least more effectively in terms of volume mobilization, to sympathetic nerve stimulation than resistance vessels do relative to their baseline state. They can achieve significant constriction even at lower frequencies of stimulation.
Do they have the same receptors as arterioles?
Mostly alpha-1 adrenergic receptors mediate venoconstriction. Crucially, veins generally lack the beta-2 adrenergic receptors that cause vasodilation in some arteriolar beds, like skeletal muscle. And they also tend to respond less strongly to local vasodilator metabolites compared to arterioles. Norepinephrine is the key neurotransmitter driving sympathetic constriction in both.
So sympathetic stimulation constricts both arteries, increasing resistance, and veins, squeezing blood out.
Exactly. Sympathetic stimulation simultaneously reduces blood flow by constricting resistance vessels, raising pressure upstream, and decreases the amount of blood held within a tissue by constricting capacitance vessels, effectively mobilizing blood from these peripheral stores back towards the heart. It's a powerful coordinated effect.
How much blood can be squeezed out of the veins?
It's estimated that approximately 1/3 of the blood volume, normally residing within a tissue's capacitance vessels, can be actively mobilized back into the central circulation when sympathetic nerves are stimulated at physiological frequencies. More blood, for instance, can potentially be mobilized from skin capacitance vessels than from muscle, partly due to their potentially greater sensitivity or perhaps lower basal tone, allowing more room for constriction.
When would the body use this venous constriction?
We see clear physiological examples during intense physical exercise. Sympathetic activation constricts peripheral veins, which helps to push pooled blood back towards the heart, increasing venous return and significantly augmenting cardiac filling, preload, supporting a higher cardiac output.
And in emergencies, like blood loss.
Absolutely critical then. In situations of arterial hypotension or hemorrhage, bleeding, the capacitance vessels constrict powerfully. This helps to compensate for the lost volume by reducing the capacity of the venous system and shunting the remaining blood towards the central circulation, attempting to restore central venous pressure and maintain cardiac filling.
What happens clinically in shock from bleeding?
From a clinical perspective, in hemorrhagic shock, resistance vessels constrict fiercely, mediated by sympathetic nerves and circulating hormones like angiotensin II and vasopressin, in an attempt to maintain arterial blood pressure despite the low volume. This intense arteriolar constriction also causes a small, but potentially crucial, mobilization of blood from the surrounding tissue simply through the elastic recoil of postarteriolar vessels as the pressure inside them drops. Furthermore, the lowered capillary hydrostatic pressure resulting from arteriolar constriction favors the movement of extravascular fluid from the tissues into the capillaries. This fluid shift acts as a vital, albeit slower, intrinsic mechanism to help replenish the circulating blood volume after hemorrhage.
Okay, that's the dominant sympathetic vasoconstriction. What about parasympathetic vasodilation? Is that a major player?
Not in terms of total vascular resistance. It's important to understand that parasympathetic fibers have a relatively small overall effect on total peripheral resistance.
Why is that?
It's because they only innervate a limited proportion of the body's resistance vessels. They're primarily found in specific areas like the head, salivary glands, cerebral vessels to some extent, certain viscera, gut, bladder, and the external genitalia. They are not extensively distributed in the major vascular beds of skin or skeletal muscle, which contribute hugely to total resistance.
So where they are present, they cause dilation. How?
Yes, where present, they mediate vasodilation through various key mediators. It's not always direct HE action on the smooth muscle. For example, in glands like your salivary, lacrimal, and sweat glands, parasympathetic stimulation leads to the local formation of a powerful vasodilator peptide called bradykinin. In the gut, another peptide, vasoactive intestinal peptide, VIP, is released from parasympathetic nerves and causes dilation. And in some vessels, neuronally released acetylcholine can stimulate the endothelial cells lining the vessel to produce and release nitric oxide, NO, which then diffuses to the smooth muscle and causes relaxation.
So indirect mechanisms often. Now back to humoral factors, chemicals in the blood. Adrenaline and noradrenaline again.
Yes. Epinephrine, adrenaline, and norepinephrine, noradrenaline, released from your adrenal medulla, circulate and have strong vascular effects. As we mentioned regarding the heart, their importance relative to direct nerve release varies. For blood vessels, low concentrations of circulating epinephrine can actually dilate resistance vessels in skeletal muscle and the liver via beta-2 adrenergic receptors.
Beta-2 causes dilation.
Right, but higher concentrations of epinephrine cause constriction via alpha-1 adrenergic effects, which usually predominates systemically. Norepinephrine, whether from nerves or the adrenal gland, consistently causes vasoconstriction via alpha-1 receptors across almost all vascular beds.
So adrenal catecholamines are generally less important than nerve endings for moment-to-moment control.
Generally, yes. For fine-tuning regional blood flow and rapid adjustments, the norepinephrine released directly from sympathetic nerve endings is considered more significant. Adrenal release provides more of a systemic, slower backup response during major stress.
And other local chemicals, from the vessel lining or tissues.
Yes, local humoral substances are also vital in regulating vessel tone right at the source. Some are released directly from the endothelium, the inner lining of the blood vessels. These include the crucial vasodilator nitric oxide, NO, another vasodilator prostacyclin, PGI2, but also potent vasoconstrictors like endothelin and thromboxane A2, involved in clotting but also constriction. The endothelium is a key regulator.
And from surrounding tissues.
Others are derived from the surrounding paravascular tissues or circulating precursors. Histamine, released during inflammation or allergic reactions, is a potent vasodilator. Adenosine, as we discussed, released from active cells, causes vasodilation. And angiotensin II, generated systemically via the renin-angiotensin system, is a very powerful vasoconstrictor involved in blood pressure regulation, all playing specific roles in fine-tuning local blood flow.
Okay, let's circle back and expand on some of those key vascular reflexes that integrate all this. The arterial baroreceptors again.
Absolutely critical for moment-to-moment blood pressure stability. As we said, located primarily in the carotid sinuses in your neck and the aortic arch in your chest.
And they sense stretch from pressure.
Exactly. When arterial pressure increases, these baroreceptors are stretched more and enhance their firing rate. This increased firing sends signals up afferent nerves, glossopharyngeal from carotid sinus, vagus from aortic arch to the medulla. These signals inhibit the tonic activity of the vasoconstrictor regions, like the RVLM, and excite the vagal cardiac centers,
Resulting in
widespread vasodilation due to decreased sympathetic outflow to vessels, and bradycardia due to increased vagal outflow to the heart, which act together to effectively lower blood pressure back towards its set point. It's a classic negative feedback loop.
Are the carotid and aortic ones equally important?
The carotid sinus baroreceptors are generally considered more sensitive, especially to rapid changes in pressure, and play a dominant role in buffering pressure fluctuations. They also respond more vigorously to pulsatile pressure, the normal rise and fall with each heartbeat, than they do to a constant, steady pressure of the same average value. The pulse adds to the stimulus.
Does this reflex adapt, like in high blood pressure?
Yes, that's a crucial point. In chronic hypertension, the baroreceptors appear to reset to a higher operating pressure. Their sensitivity may decrease, possibly due to structural changes like stiffening in the carotid sinus wall, and they start defending the higher pressure as if it were normal.
So they're great for short-term fixes, but not long-term pressure control.
Precisely. These arterial baroreceptors are absolutely foundational for buffering short-term blood pressure adjustments, like when you stand up or during exercise. But for long-term control over days, weeks, or longer, the kidneys play the dominant role through their intricate management of sodium and water balance, which determines blood volume.
In that clinical condition, carotid sinus syndrome.
Right, that's where there's abnormal hypersensitivity of the carotid sinus baroreceptors to external pressure. In affected individuals, even something seemingly minor like turning the head sharply, shaving over the area, or wearing a tight collar can trigger an exaggerated reflex.
Leading to fainting.
Yes, leading to marked hypotension from vasodilation and a severe bradycardia, potentially causing dizziness, lightheadedness, or sudden fainting syncope. It illustrates the profound power of this reflex when it malfunctions.
Okay, besides arterial baroreceptors, you mentioned cardiopulmonary ones in the heart and lungs.
Yes, cardiopulmonary baroreceptors, sometimes called low-pressure or volume receptors. They're located in the walls of your atria, ventricles, and the pulmonary vessels. They're innervated by both vagal and sympathetic afferent nerves.
And what do they do when activated, say, by increased blood volume?
Their activation, primarily by stretch, due to increased blood volume, leads to several responses aimed at reducing that volume. They notably decrease sympathetic activity to the kidneys. This promotes increased renal blood flow and glomerular filtration, leading to increased urine flow, diuresis, and sodium excretion, natriuresis. They also cause some reflex increase in heart rate via the Bainbridge mechanism we discussed.
Do they affect hormones?
Yes, critically. They inhibit the vasoconstrictor center in the brainstem, leading to some peripheral vasodilation. And importantly, they suppress the release of key hormones involved in volume retention: renin, which leads to angiotensin and aldosterone, and vasopressin, also called antidiuretic hormone, ADH.
So they are key for managing blood volume.
They play a very significant role in blood volume regulation, acting as sensors for the fullness of the circulation. Their role becomes especially evident in critical situations like hemorrhage. When hypovolemia, low blood volume, occurs, the reduced stretch on these receptors leads to the opposite effects: increased renal sympathetic vasoconstriction, reducing urine output; increased renin release, leading to angiotensin II and aldosterone production, causing salt and water retention; and increased vasopressin release, causing water retention, all working together to try and restore blood volume.
Makes sense. Peripheral chemoreceptors, again, affecting vessels too.
Yes, the peripheral chemoreceptors in your aortic and carotid bodies, primarily sensitive to low oxygen, hypoxia, but also high CO2, hypercapnia, and low pH, acidosis, while their main job is regulating respiration.
They also trigger vasoconstriction.
Yes, a reduction in arterial oxygen powerfully stimulates them. This in turn reflexively stimulates the vasoconstrictor regions in the brainstem, leading to increased sympathetic outflow and constriction of both resistance vessels, arterioles, and capacitance vessels, veins, in many vascular beds, particularly in the limbs, gut, and kidneys. This helps maintain central pressure and redirect flow to vital organs like the brain and heart during hypoxia.
What about CO2 and pH effects via these receptors?
They are also stimulated by increased arterial carbon dioxide and reduced pH, contributing to vasoconstriction. However, their reflex effect on vessels from CO2 pH changes is generally considered smaller compared to the powerful direct effects of high CO2 and low pH on the brainstem vasomotor centers themselves. But remember that synergistic effect. Simultaneous hypoxia and hypercapnia stimulating the peripheral chemoreceptors results in a vasoconstrictor response that is significantly greater than the sum of their individual effects. They amplify each other.
And angina pain is related.
Yes, it's thought that specific cardiac chemoreceptors, or perhaps pain receptors, nociceptors sensitive to metabolic byproducts like adenosine or bradykinin that accumulate during ischemia, lack of blood flow, are activated. Their signals travel via sympathetic afferents and are perceived as the characteristic chest pain known as angina pectoris.
Okay, moving up to the brain again, the hypothalamus. Beyond temperature.
The hypothalamus is absolutely essential for integrating cardiovascular responses with behavior and environmental challenges. It's crucial for optimal cardiovascular reflexes and plays a critical role in the behavioral and emotional control of the cardiovascular system. For example, as we mentioned regarding heart rate, stimulating the anterior hypothalamus can lead to a fall in blood pressure and bradycardia, mimicking vasovagal responses perhaps. Stimulating the posterolateral region typically increases both blood pressure and heart rate, similar to the defense reaction or exercise response.
And temperature regulation is key here.
Absolutely. It famously houses your body's primary temperature regulating center. This center profoundly affects sympathetic outflow to cutaneous skin blood vessels, causing vasodilation to dissipate heat when you're hot, and vasoconstriction to conserve heat when you're cold, a major controller of skin blood flow.
What about the cerebrum? Conscious thought or emotions affecting blood pressure.
Your cerebrum also intricately influences blood flow distribution and pressure. Electrical stimulation of the motor and premotor areas in the cerebral cortex typically causes a pressor response, an increase in blood pressure, likely anticipating the needs of muscle activity. However, powerful emotional stimuli processed in the cortex and limbic system can lead to quite different, sometimes paradoxical responses. Intense fear or anxiety might cause the fight or flight pressure response, but profound emotional distress or specific social situations can trigger vasodilation, like blushing in the face, or even the profound depressive response of fainting, vasovagal syncope, originating from higher centers influencing the medulla.
Pulmonary reflexes affecting systemic vessels.
Yes, reflexes originating in the lungs can affect systemic circulation. Lung inflation, sensed by stretch receptors, initiates a reflex causing mild systemic vasodilation and a decrease in arterial blood pressure. Conversely, lung collapse tends to evoke systemic vasoconstriction. These reflexes are mediated by vagal and possibly sympathetic afferent nerves traveling from the lungs to inhibit or excite vasomotor areas in the brainstem.
Lastly, central chemoreceptors, sensors in the brain itself.
Yes, distinct from the peripheral ones. There are specific chemosensitive regions located on the ventral surface of the medulla that are highly sensitive to the CO2 levels and pH of the surrounding cerebrospinal fluid, which closely reflects arterial CO2. Increased CO2 hypercapnia, stimulating these central chemoreceptors, potently excites the nearby vasomotor centers, leading to generalized sympathetic activation, vasoconstriction, and increased peripheral resistance. This helps increase cerebral blood flow to wash out the excess CO2.
And low CO2.
Conversely, a reduction in CO2, hypocapnia, perhaps from hyperventilation, decreases the tonic activity in these areas, leading to reduced sympathetic drive and some vasodilation, decreasing peripheral resistance. They are also sensitive to pH changes linked to CO2.
Does oxygen affect these central ones directly?
Interestingly, arterial oxygen levels have little direct effect on the medullary vasomotor region itself. The cardiovascular system's primary response to hypoxia is predominantly mediated by those peripheral chemoreceptors we discussed earlier in the carotid and aortic bodies. The brain relies on them to sound the alarm for low oxygen.
Okay, wow. That is an incredible amount of detail on how everything is regulated. So let's try to synthesize this. What does all of this incredibly detailed information mean for, the big picture, for a deep practical understanding?
It means the body's profound ability to precisely direct blood flow where it's most needed and expertly divert it from less active areas is a true masterclass in dynamic physiological regulation. It's a constant, intricate dance between the intrinsic controls operating within the vessels themselves, the myogenic and metabolic responses, and their overarching extrinsic commands coming from the nervous system and circulating hormones.
A constant dance. I like that.
Precisely. And for a true professional understanding, it's vital to recognize that the dominance of these intrinsic versus extrinsic mechanisms varies significantly depending on the tissue and the physiological state.
How so? Give me an example.
Well, think about vital structures like your brain and heart. They have very limited tolerance for ischemia, for reduced blood supply. So in these critical vascular beds, intrinsic flow-regulating mechanisms, particularly metabolic autoregulation, are profoundly dominant.
Meaning local needs trump central commands.
Largely, yes. For instance, even during a massive full-body sympathetic discharge like extreme stress, the sympathetic vasoconstriction in the cerebral circulation is very weak or absent. The brain powerfully protects its own blood supply, using its intrinsic metabolic control, ensuring flow matches its high constant demand regardless of what the rest of the body is doing. The heart's coronary circulation behaves similarly.
Okay, so brain and heart prioritize local control. What about somewhere like the skin?
The skin is different. Here, extrinsic control via sympathetic nerves, orchestrated by the hypothalamic temperature-regulating pathways, meticulously handles heat loss and conservation. That's usually the dominant factor. But fascinatingly, strong local temperature changes, like putting your hand in ice water or warm water, can actually override that central sympathetic influence in the affected area. It demonstrates a remarkable interplay where local conditions can ultimately dictate the response, even against the larger system's commands for temperature regulation.
So local can win out there, too, under specific conditions. Now, the really complex one, skeletal muscle.
Skeletal muscle. Yes, the interaction there is perhaps the most complex and illustrative of this whole balancing act. In resting muscle, extrinsic neural control, specifically the tonic vasoconstrictor tone from sympathetic nerves, is dominant.
How do we know?
Because, as we mentioned, if you block or cut the sympathetic nerves to a resting muscle, you observe a large immediate increase in blood flow. This shows that baseline sympathetic tone was significantly restricting flow at rest.
But what happens during exercise?
That's where the switch happens. Once exercise begins, the intrinsic metabolic flow regulating mechanism immediately takes over in the active muscles. Profound vasodilation occurs due to the rapid buildup of local metabolites, low oxygen, high CO2, adenosine, potassium, etc. This local metabolic signal powerfully overrides any constrictor impulses arriving from the general sympathetic discharge that's happening system-wide during exercise. The local need for oxygen completely dominates.
While the inactive tissues are constricting.
Exactly. Meanwhile, that same generalized sympathetic vasoconstriction is effectively shunting blood away from inactive tissues, like the gut, kidneys, and active muscles, to prioritize flow to the working muscles where the local metabolites are causing dilation. It's a dynamic, essential redirection of the entire cardiac output.
This masterful dual control ensures that blood flows precisely to where it's most required, while simultaneously conserving precious resources from inactive areas. It's amazing.
It really is.
Yeah.
Consider this final example. Even with an increased level of carbon dioxide in the arterial blood systemically,
Yes.
which would normally stimulate central chemoreceptors and cause generalized vasoconstriction,
Yes.
the local effect of that high CO2 within the actively metabolizing muscles causes potent arterial relaxation and vasodilation there. So the systemic signal for constriction is overridden locally where flow is needed most. It's a beautifully coordinated, highly adaptive system, perfectly designed to match supply with demand across the entire body under diverse conditions.
Wow. Okay. From the imperceptible movements of calcium within a single heart muscle cell to the grand global orchestration of blood flow across your entire body. This deep dive has truly laid bare just how incredibly regulated and exquisitely balanced our cardiovascular system is. It's a profound testament to the body's adaptive genius, constantly balancing intrinsic and extrinsic signals, micro and macro adjustments to keep us alive, thriving, and performing at every level.
Understanding these intricate layers of control, from the rapid, beat-by-beat fine-tuning by the vagus nerve to the powerful force modulation by the sympathetic system and intrinsic mechanisms, right through to the long-term, systemic volume control orchestrated by the kidneys and cardiopulmonary reflexes, truly equips you with a master's perspective on human physiology. It doesn't just present isolated facts. It highlights the profound, indispensable interconnectedness of our biological systems, giving you, hopefully, a true professional's command of this field.
Absolutely. So for your final thought to mull over, really to take away and consider from this deep dive, given this constant, precise push and pull we've explored between the intrinsic local controls and the overarching extrinsic commands, what innovative implications might this dynamic have for the future development of highly targeted therapies for cardiovascular diseases? Especially thinking about scenarios where one system, say sympathetic drive, is chronically overactive, or maybe local metabolic control is impaired, throwing the whole beautiful orchestra out of tune.
That's a truly fascinating question, and it cuts right to the heart of applying this deep physiological knowledge to real-world clinical challenges and future therapeutic design. A perfect place to pause and reflect. Keep exploring, keep learning, and keep asking those deep questions.